Good evening. We'll welcome you to our last session for 2014 for the College of Pediatrics, and likewise, we have our posada for the last part of the year for Christmas celebrations. We want to thank physicians who are going on to the platform on the internet who are watching us in different parts of the Republic, given that today we also have the service, and as mentioned before, this conference will be recorded by the Office of Certification for Pediatrics, and we're going to join 13 points throughout the year for this. Up next, we have Dr. Fernando Contreras, who will give a readout to the previous conference since November.
Buenas noches.
Good evening. Good evening.
Sesión académica del Colegio Pediatric correspondiente al mes de noviembre del año 2014.
Ok, sí, para que también nos sirva de preguntas y respuestas. Sí. Gracias. Hall F on the 8th floor of Convex, we're having a record of assistance of 253 associates, of which 232 were present and 21 were online through internet. As our first part, we want to welcome all our assistants here tonight and associated, connected associates through internet in the different states of the Republic on behalf of Dr. Sabriano Leal Salinas, president of the current college. Up next, we had a readout of the minutes by Dr. Fernando Contreras Salazar, which was approved by unanimity. And during the ordinary course of the session, Dr. Manuel Ochoa Hernandez offered a second offer for a second Pediatrics Congress on the 15th of December with a cost of 2,600 pesos. Que te lo regrese.
El desarrollo de la práctica académica de nuestra pasada sesión correspondió a la doctora Gloria María Rosales Solís, dermatóloga pediatra, con el tema Manifestaciones dermatológicas secundarias a deficiencias vitamínicas. Al término de nuestra ponencia tuvimos la participación de la doctora María Heréndida Siqueiros Loranca con el tema Importancia de la suplementación de vitaminas en edades tempranas.
Finally, it was we were told about our academic session on the 4th of December with the topic Progress in Nutrition in Preterm and Post-Term Babies on behalf of Dr. Kimmo Makinen, an immunologist physician from the from the University in Aberdeen. Our last session was sponsored by Dr. Siegfried, so this is the previous. We're going to. They were reading the main points of the previous meetings that they had at college. The topic we're going to be seeing today is preterm and term child nutrition by Dr. Kimmo Makinen, who I inform you that on the outside we have translation devices for if you were to need these, given that this presentation will be made in English. Dr. Kimmo Makinen has an academic degree in biomedicine and a PhD in immunology by the University of Aberdeen in Scotland. After his PhD, he worked at the University of Oxford in England in cardiovascular research. Since 2009, he's been a scientific assessor for the Nestlé Center for Research in Switzerland, expert in probiotics and coordinator for activities for research related to the topics, especially child nutrition. During his career, he's received awards for his work in research by the University of Oxford and Germany. His recent publications regarding probiotics include a meta-analysis in the Journal of Nutrition 2013 and also a scientific paper on the use of probiotics and nutritional products in the Journal of Technology in 2012. We want to pass the mic over now to Dr. Makinen so he can come and speak to us. Thank you.
Thank you very much for that introduction. Good evening, ladies and gentlemen. It's a real pleasure for me to be here tonight in Monterrey. It's actually my second time in Mexico, but this is my first time visiting the city of Monterrey. And on my way from the airport, we already had an opportunity to sample the great steaks, the meat of Monterrey, which I'm told is world famous, and I can certainly understand why that might be the case. So tonight, it's a great pleasure for me to give you this little lecture on the use of probiotics in pediatric populations. And just to manage expectations a little bit, tonight what I'm going to be talking about is mainly full-term infants, not really going into the preterm area very much, but there's a lot to say in full-term babies as well. So what you see in the picture here is the Nestlé Research Center in Lausanne in Switzerland, where I'm based. It's located near the Lake Geneva in the French-speaking area of Switzerland, and it's not. Excuse me. Oh, I seem to have this problem again. Oh, I tell you what is wrong. It's because this laptop here is not synchronized with the clicker, so I thought nothing was changing when the slides were changing, actually. So we have research locations also elsewhere in the world. For example, in USA, in St. Louis, we have Purina Pet Care Research. In Beijing, we also have a research center on brain development, aging, metabolic health, cardiovascular health, and traditional Chinese medicine. And also in Tokyo, we have a small research center where we look at aging and health biomarkers. And as a research organization, we manage to publish around 200 peer-reviewed publications every year. And we also file a lot of patents across different disciplines every year. In addition, we have more than 30 product technology and R&D centers around the world and more than 300 application groups. There's also one application group in Mexico, in Querétaro, where we do some research on Gerber infant and child food products. In the Nestlé Research Center in Lausanne, specifically, we have a research program which is divided into 5 parts. We have a food safety and integrity program. We study first 1,000 days healthy kids, healthy aging, healthy pleasure, and sustainable nutrition. And what I'm about to tell you today is research from within the first 1,000 days and healthy kids research program. And specifically, I want to talk about today about probiotics, because that's where my specialty and expertise lies. And I want to tell you about the use of probiotics in the management of and prevention of gastrointestinal infections, and also probiotics for gut comfort. Now, when we talk about probiotics and when we talk about protection against infection, it's very important to talk about gut microbiota. Now, all of us, we have a very rich gut microbiota inside of our intestines. We have about 10 to the 14 bacterial cells inside all of us. Collectively, they weigh about 1 to 2 kilos, and they perform very important functions. For example, they are involved in the regulation of metabolism, protection against infections, and also digestion of nutrients that we otherwise could not digest with our own digestive enzymes. And we also know that in addition to having beneficial functions, the gut microbiota can also have components which are potentially harmful to us. And that's why it's so important to maintain a balance between the good components and the potential harmful components of the gut microbiota. Now, even though today we all have gut microbiota, that wasn't always the case. Because all of us are born virtually sterile. But immediately after birth, the infant's gastrointestinal tract begins to be colonized by microbes. So when the infant is born, it passes through the birth canal. if it's born naturally. And during that process, the infant becomes inoculated with microbes from the mother's vaginal microbiota and also rectal microbiota, which serves as a kind of starter culture in the gut, which then starts the colonization process. And as you can see here, very soon in the infant's gut, bifidobacteria become the prominent microbial component. However, if the infant is born by cesarean section, things work a little bit differently, because that initial inoculation event does not occur because the baby is not coming through the birth canal. And we can also see that that has an impact on the development of the bifidobacteria microbiota. You can see that compared to the vaginally born babies, in infants born by C-section, the development of bifidobacteria microbiota is delayed by about 30 days. If you profile the microbiota a little bit deeper, we can see that infants born by vaginal birth have a microbiota which is very similar to the vaginal microbiota of the mother, whereas cesarean section born babies have a microbiota that is very similar to the skin microbiota of the mother. And we believe that these differences in the microbiota have also very important consequences on the infant's health, because several studies have shown that infants born by C-section have a high rate of asthma and various allergic conditions, and also gastrointestinal infections. So the kind of microbiota that you have definitely makes an impact on the child's health. So it's important to nurture the development of beneficial microbiota in infants. The best way to do this is, of course, by giving the baby breast milk, which is the gold standard in infants' nutrition. Many studies have shown the benefits of breast milk. For example, breastfed babies have a reduced risk of infant death, respiratory infections, gastrointestinal infections, otitis media, and even necrotizing enterocolitis. And it's not surprising that breast milk is so beneficial to the infants, because it contains many beneficial components, such as macronutrients, but also vitamins and minerals, and also components that modulate the function of the immune system. And it's through our increasingly good understanding of the composition of breast milk, as well as the specific needs of infants, that we have been able to develop infant formula, which is the only credible and safe alternative to breastfeeding, to a point where it no longer simply provides basic nutrition or optimal nutrition, but to a point where you get nutrition, and in addition you get beneficial physiological benefits, such as protection against infection and improved gut comfort. For example, we have shown that through administration of the probiotic Bifidobacterium lactis, we can promote the development of Bifidobacteria flora in infants. You can see, for example, here that infants who are given a formula containing B. lactis have the prevalence of Bifidobacteria which is comparable to breastfed infants. And compare that with a group of infants who did not get Bifidobacterium lactis but only got infant formula. We've also shown the benefits of B. lactis administration in preterm infants. And as you probably know, preterm infants have a highly disturbed gut microbiota, because the majority of preterm infants are born by C-section. They also have a highly immature gut, and they are also usually on antibiotics, which disturb microbiota in their own right. So by giving B. lactis to preterm infants, we've been able to increase the number of bifidobacteria compared to the placebo group, also reducing the number of potentially pathogenic enterobacteria and clostridia in the preterm baby's guts. So through the administration of probiotics, we can positively influence the microbiota in term and in preterm babies. Now, you may ask me, so what? What does it matter this microbiota balance because it's not a health benefit in its own right. And that's true. So in order to find the real health benefit behind these changes, we have to look a little deeper. One thing that we know probiotics are able to do is to interact with the immune system, and through that they can promote immune maturation and also stimulate immune reactions. We've done some animal experiments that show very interestingly that if you label probiotics with a fluorescent dye, which is shown here in green, and then you see what happens inside the animal when you feed them these probiotics, you can see that the probiotics move from the lumen of the gut into the immune cell area inside the gut wall, and finally they end up inside the dendritic cells, which are the antigen-presenting cells of the body, which can then initiate and modulate immune responses. We've also shown, using animal models of neonatal immune development, that if you give animals B. lactis, they have a higher number of soluble IgA secreting cells in the feces, which shows that their immune system is developing better than in the case when only placebo was administered. In infants, actually, these immune benefits are also tangible, because in preterm infants we have shown that the administration of B. lactis can promote the secretion of soluble IgA in the feces over the placebo group. And also in C-section babies, we've shown that these babies respond better, significantly better, to polio vaccination if they are given the probiotic B. lactis compared to the placebo group. These immune-related benefits also translate to direct clinical health benefits in terms of protection against gastrointestinal infections. For example, in this study, which was published in Lancet in 1994, it was shown that in hospitalized full-term infants who got the probiotic B. lactis, there was a significantly lower incidence of hospital-acquired diarrhea. And also in cases where there was a rotavirus infection, the rotavirus shedding was lower in these infants who received the B. lactis probiotic. Also in a community setting, so these are free living infants living at homes, receiving probiotic B. lactis, we have shown that infants who receive the probiotic B. lactis have a lower incidence of diarrhea compared to those who only receive the placebo formula. Collectively, if you look at the situation in a meta-analysis, this was a meta-analysis that was published by Espacan in 2011. It was shown that if you combine the results of 3 studies with B. lactis, you end up with a result of risk ratio of 0.54 of getting gastrointestinal infection, so about halving the risk of gastrointestinal infection in infants given B. lactis in formula. So that's all I wanted to say about probiotics for control of gastrointestinal infection. And what I would like to do in the rest of this presentation is now focus my attention on probiotics for gut comfort. And in particular, I'd like to focus on infantile colic because it's such a prevalent problem and also something that concerns parents to a great degree. So infantile colic, as you probably know, can occur in up to 40% of babies. It's common in both bottle-fed as well as breastfed babies. There doesn't seem to be any difference between those two groups in terms of incidence. It usually starts in the first week of life and can drive up to 25% of pediatric consultations. And also, if you look at the kind of information that parents are searching on the internet, infantile colic is by far the most searched gastrointestinal problem that parents want to find more information about. So it is a problem that concerns parents as well as the medical profession in general. Infantile colic, just a little refresher, is defined by Wessel's criteria, by the rule of 3s. So an otherwise healthy infant who cries for at least 3 hours a day, 3 days a week, at least 3 weeks in a row would be classified as having colic. There's also an alternative definition, which is the Rome 3 criteria, where the infant cries 3 hours a day, 3 days a week, at least 1 week. That would also be classified as having colic. And even though colic is a self-limiting condition that usually resolves spontaneously within the 3 to 4 months of age, it can have some longer-lasting consequences and also consequences to the mother. For example, studies have shown that if you had colic as an infant, you are at higher risk of having sleep difficulties at 3 years of age and also at 10 years of age. Also, if you used to have colic, you have a higher risk of getting functional abdominal pain, recurrent abdominal pain at the age of 10 years. Also in mothers, and perhaps this is not a great surprise, mothers of colicky babies have far higher postnatal depression scores compared to mothers who had non-colicky babies. So it's a problem that even though it disappears, it's clearly important to try to deal with that as effectively as possible. But what makes it so difficult and challenging to deal with colic is that even though we've been studying it for years, we still don't fully understand what causes colic. There are several theories around the subject. For example, there are gastrointestinal theories that suggest that perhaps colic is caused by hypertonicity or hypercontractility of the gastrointestinal system, or simply immaturity of the gastrointestinal tract. There are behavioral and psychological theories according to which the mother or the parents are perhaps not bonding well enough with the infant, or they are not responding well enough to the infant's needs. And then there are finally the dietary factor theories, which suggest that perhaps things like cow's milk allergy could be the causative factor in infantile colic. But we have all these hypotheses, but we don't really know the actual answer what causes infantile colic. And in many cases, colic can be multifactorial. But what we have noticed by profiling the microbiota of colicky versus non-colicky infants is that colicky babies have a lower prevalence of beneficial lactobacilli compared to non-colicky infants. And the reason why we think this is important is that lactobacilli produce beneficial substances like short-chain fatty acids, which are required for the proper functioning of the gut musculature as well as the gut epithelium. Also, we've seen that colicky babies have a higher prevalence of coliform bacteria and Escherichia coli, which are known producers of intestinal gas. And you can imagine that perhaps in colicky infants you might have excess gas production because of this bacterial imbalance, and that could be partially causing the colicky episodes. What I now want to talk about is the use of Lactobacillus reuteri to deal with infantile colic. Lactobacillus reuteri is a probiotic that was first described by the German professor Gerhard Reuter, and he described it as a natural inhabitant of the gastrointestinal tract of the humans. And it's in fact as a species found in all parts of the gastrointestinal tract, from the mouth all the way to the anus. It's also found in the breast milk of many lactating mothers, and in fact, we first isolated Lactobacillus reuteri from the breast milk of a Peruvian woman. It can be also found in the vaginal microbiota, which means that during birth, babies can become naturally colonized by the species Lactobacillus reuteri. So it's a kind of species with which we have been living together for centuries, if you like. We have shown, in terms of microbiota composition in colicky infants, is that Lactobacillus reuteri administration can, in fact, reduce the number of these gas-producing E. coli bacteria in colicky babies, and also significantly increase the number of beneficial lactobacilli. Now, I'm not saying that this is fully accounting for the beneficial effects of L. reuteri that I will describe to you in a minute, but I think this will at least have a significant component in the mechanism of action of Lactobacillus reuteri. So let me now show you some studies that we have done in colicky babies. Here's simply one example of a typical study design to give you an idea how you would design such a study. This was published by Sajewska et al. In 2013, and in this particular study, we recruited 80 colicky infants who were less than 20 weeks at enrollment. They were all exclusively or predominantly breastfed. The Bacillus reuteri given in oil drops or corresponding placebo drops that did not contain any probiotics. And the treatment was given for 21 days. And what we then asked, we asked the parents to use a structured diary to record the daily crying times in these infants. So every time your baby is crying, you're marking down the duration of that crying episode, and finally you end up with the total crying time for a particular day. I'll now show you the results of 5 different clinical studies. This one was done by Francisco Savino in Italy in 2007. And here what was compared was Lactobacillus reuteri versus simethicone, which is a commonly used over-the-counter medication for colic. And what this study showed quite elegantly was that over the study period, the crying time in the L. reuteri group significantly reduced compared to the control group, the simethicone group. Savino also did another study a few years later, also in exclusively breastfed infants, and he showed again a similar result where L. reuteri group cried significantly less throughout the study compared to the placebo group. Sajewska et al., then this was a study done in Poland, replicated the result, very similar result. Then earlier this year, I don't know if you've heard about this study, but to our great surprise, there was one study published in Australia where we did not see a similar effect. We have some ideas and some plausible hypotheses why this might be the case, but we were surprised that we did not see a similar positive effect we've seen in the previous 3 studies. But only 1 month ago, there was a 5th study that was done in Canada that was published, and it yet again replicated the positive findings we've been getting with L. reuteri in infantile colic over the years. So we are very confident that this is an intervention that certainly works for the treatment of infantile colic. And in fact, if you look at this situation globally and you do a meta-analysis, we can see what the average effect of these interventions are. And to do this meta-analysis properly, what we've done here, this is some unpublished data. We've taken all the studies we can pull into meta-analysis, and we looked at data from 21 the data point day 21 only, and we've excluded the first study by Savino 2007 because it was not placebo-controlled. It was controlled against simethicone, so we cannot put that together with the placebo-controlled study, so we're leaving it out of this meta-analysis. And we only used the randomized placebo-controlled studies. And if you do this meta-analysis, you see that despite one study that did not show an effect, we still have a significant effect in favor of L. reuteri intervention. So there's about 50 minutes less crying per day in the L. reuteri group versus the placebo group. So everything I showed you so far concerned the treatment of infantile colic. What about prevention? Could you use L. reuteri to prevent the appearance of colic in the first place? This study that was published by Flavia Indrio earlier this year tried to address that question. So in this study, we recruited 554 healthy newborn infants, and these infants were less than 1 week of age at enrollment. And at that age, you don't have colic yet, so everybody was colic-free when they were enrolled into the study. They were then randomized to receive for 3 months either L. reuteri drops or corresponding placebo drops. And the parents were again asked to record the daily crying times using a structured diary, and also the number of defecations per day, and also the number of regurgitations per day. And also this study looked at the health economic impact of L. reuteri intervention, because it's also important to understand how an intervention which is effective can reduce the cost to the family as well as the society. And what these results showed is that indeed it looks like L-reuteri can also work in a preventive setting, because the infants who received L-reuteri cried about 53% less compared to the placebo group. There was also a clear health economic impact. So if you look at the various factors, you will see that the L-reuteri group had far fewer pediatrician visits, also a fewer number of emergency room visits, less lost parental working days, lower percentage of families who went into the pharmacies and bought simethicone or other medications which are intended to treat infantile colic. If you then do the calculations, and these numbers here are in US dollars, but they are actually based on the current prices in Italy, where the study was done, we found that the L-reuteri group spent significantly less money compared to the placebo group. So there was a significant saving to the family, and the same was true in terms of saving to the society. So L-reuteri group cost the society less than does the placebo group. In this particular study, we also saw that the infants who took L-reuteri had a higher bowel frequency compared to the placebo group. None of these infants were constipated based on these figures, because the bowel frequency is quite high. But we've also shown in a separate study, I'm not going into the details here, I'm just showing you some data to give you the idea. So this was a study done in constipated infants who were then given L-reuteri, and we looked at the number of infants who then acquire the normal number of bowel movements. And we saw that throughout the study, the infants who had 5 to 7 bowel movements per day were far more prevalent in the L-reuteri group compared to the placebo group. So what that shows is that L-reuteri can promote gut movements in a preventative way, as well as treat constipation when it has already begun. We've also seen that L-reuteri can reduce regurgitation in infants. In this study, these infants all had functional regurgitation, but then throughout the study, when they were given L-reuteri, the L-reuteri group reduced the number of regurgitation to only 1 regurgitation per day. So what this has then shown is L-reuteri can do several things related to gut comfort. It can help treat infantile colic, it can help prevent infantile colic, it can help deal with constipation, and also reduce spitting up or regurgitation in infants. So finally, just to summarize what I've said in my presentation, what we can achieve with the administration of probiotics is that we can promote the microbiota balance and give the babies a good start to life, which can then lead to reinforcement of immunity, gut maturation, and gut function. And the kind of health benefits you can achieve through this relate to immune protection, protection against infections like GI infections, as well as gut comfort like reduction of colic and constipation. And then overall, what this leads to is better health outcomes in the infants. So that's all I wanted to say to you, ladies and gentlemen, tonight. I thank you very much for your attention.
Wait to raise your hand. No questions? Manuela, is there something through the internet? Any questions? I do have a question for you, Doctor. What is the future for probiotics in the future, knowing quite well that the production of antibiotics is going down? I've heard that there's conversations that probiotics are going to be the most important management for diseases, going from diabetes, cancer, and immunology. What are your views on this?
So thank you very much for the question. That's a very interesting question, and it is true that probiotics have a great potential. Actually, today there are about 1,400 clinical studies published on the various health benefits of probiotics. They are spread, the studies, over many, many different health benefit areas as well as different target population. And it's true when it comes to infection control, there are some evidences such that for certain things like Clostridium difficile infection, which is very difficult to deal with using antibiotics, probiotics have actually been shown to help in that kind of context. And also protection against gastrointestinal infections, of course, unless you have rotavirus infection, which you might deal with rotavirus vaccination in a prophylactic way. There are very little things you can do to prevent these things. So yes, probiotics could be very useful in this sort of context. And a lot of probiotics actually, they produce antimicrobial substances which can be used to fight pathogens. So I firmly believe that, you can develop probiotics which can replace or at least complement antibiotic treatments. Now, in terms of diabetes, even though this kind of data doesn't really exist in infants yet, it's being acquired, and already in adults it has been shown that probiotic administration can help improve glucose tolerance and also help with gestational diabetes during pregnancy. So I think the research is evolving in this direction. In terms of cancer, yes, why not? I've seen a few studies in adults where, for example, colorectal cancer seems to have improved and the reappearance of tumors has been reduced thanks to probiotic administration. But again, it's one of these new fields which are currently being investigated where I think probiotics have a lot of promise, but we just have to wait for the evidence to appear.
¿Alguna otra pregunta?
Through the
internet, they're asking a question. They say, is there any other bacilli that can be used with the same efficiency? And if it's important, the hours when we administrate it? The therapy with B. lactis or lactobacillus.
So if we're talking about these very same health benefits that I've described today, which is protection against gastrointestinal infections and gut comfort and infantile colic, yes, there are some other probiotics that have been investigated for gastrointestinal infections. One just needs to dig through the literature, and you will find some examples where they have worked. In various settings, for example, against gas-associated diarrhea, there's some very interesting evidence that has come out with probiotics. And I think the evidence exists both in lactobacillus and bifidobacteria groups for infection control. Now, when we talk about infantile colic, there are maybe a couple of other bacterial solutions that have been looked into this health benefit, but in terms of pure number of studies, they do not match what L. reuteri has behind it right now. So we're talking about L. reuteri now has 5 studies on purely infantile colic, whereas the other solutions maybe have 1 clinical study, so they have to acquire far more data. But yes, what often happens is that you have a probiotic health benefit, and you have one solution, one probiotic that has been substantiated to the greatest extent for this particular health benefit, and then you may have some few other solutions which are not quite at the same level of evidence right now. So the answer is yes, probably there are solutions, but the degree of evidence is likely to be a little bit different.
Well, thank you. Any more questions? No? Okay, then we want to thank you, Dr. Kimmo, for your presentation. We want to give you a momentum and a gift.